Good afternoon, everyone. Today I'll be discussing a study on comparison of bent ab interno needle goniectomy versus goniotomy in PCG eyes. At the outset, I would like to declare that this study was recently published in Ophthalmology Glaucoma in the fag end of December last year. So in our study, as we all know, primary congenital glaucoma is a primary developmental anomaly of the trabecular meshwork, and the mainstay of treatment is surgical intervention. So surgical intervention is determined by the corneal clarity. If the cornea is clear, then we go ahead with ab interno procedures such as goniotomy, and when the angle is not visible, then we go ahead with ab externo procedures. So goniotomy was the first angle surgery described by Barkin, and it basically enhances aqueous humor outflow by incising the trabecular meshwork. And the surgical success that we know at around 1 year is 60 to 80% in various studies. And BANG stands for bent ab interno needle goniectomy, which is a variation of Barkin's technique given by Shute, and it uses a bent 25 needle reverse cystotome, which excises the trabecular meshwork instead. So we had a study research question: will the stripping of trabecular meshwork offer any additional benefit over simply incising the tissue in infantile PCG eyes? For this, we did a study to evaluate the efficacy of BANG compared to the established standard of traditional goniotomy. Our study was a prospective interventional parallel group randomized control trial in which we included infants with bilateral symmetrical PCG with an onset of glaucoma in 1 month and 1 year of age with no prior history of ocular surgery and a corneal clarity grading of less than 2. One eye of each infant was randomly assigned either to goniotomy or BANG with a 1:1 computer generated randomization, and the outcome measures were IOP control and the requirement of anti-glaucoma medications. Secondary outcome measures were complications of surgery and the requirement of additional surgery. Complete success was if intraocular pressure of less than 18 was maintained without medication, and qualified if maintained up to over 2 medications. Failure if more than 2 medications were required or a resurgery was required. The baseline characteristics of goniotomy and BANG of each eye were comparable for these parameters, which were assessed: corneal diameter, mean corneal clarity grade, axial length, intraocular pressure, cup-disc ratio, central corneal thickness, baseline number of medications, and mean degrees of angle treated. All of these were statistically similar in both the eyes. Outcomes were measured at 3 months, 6 months, and 1 year of duration. The intraocular pressure at the outset was 24 and 25.5 in the goniotomy and BANG group respectively, and at the end of 1 year, we can see that it had decreased to 15.3 and 17.1, but both of them were statistically similar at all the follow-ups. Similarly, for the number of anti-glaucoma medications, at the beginning it was 1.7 and 2 in the goniotomy and the BANG group, and at 1 year of follow-up, it had decreased to 1.14 and 1.28 with no statistical difference at any standpoint. This graph summarizes the entire study, in which we can see that the line diagrams are showing the degrees of angle treated for each eye in the BANG group and the goniotomy group, and the extent of angle treated was similar in both the eyes of each patient. And for all the patients, the bar grams are determining the pre-intervention IOP and the post-intervention IOP. And we can see in the goniotomy group, 3 eyes were medication free at 1 year, which was a complete success. 4 eyes were qualified success, and 1 had failed at 1 year follow-up. 2 BANG eyes were medication free at 1 year, 4 were qualified success, and 2 had failed in the BANG group. Hyphema was the only complication noted in the goniotomy group. 2 eyes had hyphema, which resolved within 2 weeks, and BANG group had 3 eyes had hyphema, which resolved again within 2 weeks without any intervention. So we could demonstrate comparable success in both the groups, and added complexity of excising the meshwork did not confer any additional benefit in the PCG eyes. We can say that the IOP lowering effect may be attributed to the angle widening and falling back of the highly inserted peripheral iris regardless of the amount of trabecular meshwork tissue removed. Our study is limited by small sample size, but it had a stringent study design, and we can confer that goniotomy remains a reasonable surgical procedure in PCG eyes. Thank you.
Thank you. Do you think with such a small sample size, can we draw any clinically useful inference from this study?
So because the eyes were exactly similar in all of the parameters, such as intraocular pressure was less than 3 millimeter difference, and axial length of less than 1.5 millimeter difference between each eye of each patient, and cup-disc ratio of less than 0.2 difference between each eye of each patient. So we know that both the eyes were very, very similar in the parameters that were being assessed. So even though the sample size is small, I agree on that, but the result then
Sushmita
becomes
Joshi, please come
significant.
here. Okay. Any question?
The complication rates were nearly similar, right?
Yes, sir.
Okay.
So how long was your follow-up?
Ma'am, 1 year.
1 year.
We're currently doing a 2-year follow. We'll be publishing the results soon, ma'am.